to the MCPAP Clinical Conversations. My name is Beth McGinn. I am the MCPAP Program Manager. As you know, usually Dr. Savette is here kind of moderating, but I am stepping in on his behalf today. So welcome to Clinical Conversations. It takes place on the fourth Tuesday of every month. The next clinical conversation is on June 27th, and the topic will be MCPAP for early childhood and overview. And today's topic is Obsessive-Compulsive Disorder and Tics in Pediatrics. Just some basic housekeeping. There's no CMEs. CMEs will return in the fall sessions. The sessions will continue to be recorded and be available on our website, which is mcpap.com. And a copy of the PowerPoint slides will be available on our website on the toolkits and resource page under PowerPoint presentations. Our presenters will stop for questions at several points during the presentation to see if, and we'll also have time at the end. And today we'll be wrapping up a little bit earlier than the 1:15. But if you have a question, please type the question into the question box during the presentation, and we'll read out the question or unmute your line for you to ask the question. You'll receive a brief survey following the presentation, and we appreciate any feedback to help us improve for future presentations. But now I have the distinguished pleasure of introducing today's presenter, who is Dr. Erica Greenberg, who is a child and adolescent psychiatrist at MGH and is an assistant professor in psychiatry at Harvard Medical School. Dr. Greenberg is the director of pediatric psychiatry of OCD and Tic disorder program at MGH, is the co-director of the MGH Tourette's Association of America Center of Excellence, and a medical advisory on the medical advisory board at TTA or TAT? TAA. Her interests include Tourette syndrome, OCD, Tourette OCD, ADHD, body focus, repetitive behavior disorders, and other Tourette syndrome and conditions. She has authored and several peer-reviewed manuscripts on Tourette's as well as OCD and related disorders, and has been presenting these conditions nationally and internationally. And Dr. Greenberg graduated from the Weill Cornell Medical School with an Omega Alpha honors, and completed her general psychiatry at Harvard here in Boston, and her child and adolescent fellowship training at MGH and McLean, where she served as chief resident for both programs. So with that, I hand things over to Dr. Greenberg. Thank you for being with us today.
Yeah, thank you so much for having me, for introducing me, and I will share my screen. Okay, and then cool. Is this working?
Yes, it is.
Awesome. All right. And so good. Okay. So my name is Erica Greenberg, and I'm the director of the Pediatric Psychiatry, OCD, and Tic Disorders program at Mass General. And today I'm going to be speaking about OCD and tics in pediatrics, but I'm mainly going to be focusing on tics with just a little bit of content on OCD. Here are my disclosures, but none particularly interfering. Learning objectives are going to be to describe the diagnostic criteria for OCD and tic disorders, most effective first-line treatments for OCD and for tics, and then describe how OCD with tics is actually different from OCD without tics. And so starting with OCD, many of you probably already know this, but just to review, it's diagnosed by having obsessions and or compulsions. Obsessions meaning unwanted, intrusive, fixed or repetitive ideas, thoughts, images, or impulses. Again, though, these are unwanted. And compulsions being behaviors that one feels as though they must do to get rid of that unwanted feeling caused by an obsession or in order to follow specific self-determined rules. In order to meet criteria, though, for OCD, it has to take at least an hour a day, and it needs to cause at least some degree of distress and or impairment. There was a really interesting study out of Philadelphia a number of years ago that gave a survey to, I think it was upwards of thousands, tens of thousands of school children. 40% of kids will have at least one OC symptom. About 15% will have some symptoms, but it takes less than an hour a day and is not necessarily impairing. And 2 to 3% will have formal OCD, where these are taking at least an hour a day and causing distress and impairment. We often talk about having insight in OCD, and for a while it was believed that children don't necessarily have insight into their symptoms, meaning they feel oftentimes in OCD, someone will feel as though they have to do something. They recognize that it doesn't make sense, but they still feel as though they have to do it. When there's no insight, one is unable necessarily to say that they realize that this doesn't necessarily make sense. But overall, kids do typically have some degree of insight. Perhaps really little kids might not. And sometimes they might even say things like, a voice is telling me to do that, especially, 4, 5, 6. But in general, there's usually insight. And then another modifier in terms of the DSM is whether it's tic related, and I'll get into why that's important later. And so, as I mentioned, it impacts about 2 to 3% of children and adolescents. It's a bimodal age of onset, meaning there's the early onset, usually around 8 to 12, a little later in girls compared to boys, and then a second onset in the late teens, early adulthood. What's really important about OCD is when you see it, be aware of co-occurring conditions. So at least 50% of youth individuals with OCD will have at least one co-occurring condition, including other obsessive-compulsive related disorders, hair pulling, skin picking, body dysmorphic disorder, anxiety disorders, tic disorders, ADHD, which is pretty commonly overlapping, mood disorders, and in general, in OCD, I'm not going to get into PANS, PANDAS today, but in general, the course waxes and wanes and frequently tends to be chronic over time. We're often asked by parents whether it will resolve on its own, and per some of the limited studies we have, about maybe 10% plus minus might self-resolve. I'm not sure I would necessarily totally stick to that fact, but overall, we know that the outcomes in pediatric OCD are pretty good, with about 60% 7 to 12 years later, either being mild symptoms or remitted symptoms. Whether or not that's still with them taking medication and or therapy, that's not noted, but in general, outcomes are not so bad with pediatric OCD. And one area that I also really like to focus when talking about OCD is the different subgroups and feeling states that link to the symptoms. So when people hear OCD, often they think like hand washing or contamination, but that's actually just one of the subgroups that we often see. And so the 4 different subtypes are symmetry, and that's things like writing, rewriting, reading, rereading. If you touch your left, you have to touch your right. Then there's a category called forbidden thoughts, which is sometimes divided into 2 categories: taboo thoughts, and that's what people will sometimes refer to as the pure O, pure obsessions. So these intrusive, aggressive, sexual, religious, moral thoughts. And then sometimes there will be commensurate mental compulsions to eliminate the bad thoughts. I just had a thought of something I didn't want to see. Now I have to look around the room for 3 things that are good. And then the other part of forbidden thoughts to keep an eye out for is doubt and checking. And so this is a lot of, in little kids, you'll sometimes see a lot of confessing. So was this okay? I think I just stole something. Are you sure I didn't? What if I did? I think I stuck my tongue out at that kid. So those are some of the examples, and you'll see a lot of reassurance, again, a lot of reassurance seeking. Was that good? Yes. Are you sure it was good? Yes, et cetera, et cetera. Also, sometimes a lot of body-focused complaints, which you obviously see in anxiety too, but just excessive worrying. Does my stomach hurt? I think it hurts. What if I'm going to vomit? Et cetera. The third category is cleaning contamination, which is the one people often think of with OCD. And then the last one is hoarding, but that was actually taken out of being an OCD symptom, and now it's its own disorder. The other important thing is that when people hear OCD, they often think that the obsession is related to a fear. If I don't touch this, this bad thing will happen, and I'm afraid that by not doing it, it will cause this thing. That is one of the feeling states that can precede engaging in compulsions, anxiety. But two other ones that often aren't asked about as much, but would be important to be aware of, are disgust. So like just the idea of thinking about it makes me disgusted. I'm not worried something will happen. I just can't. And the other one is not just right. So again, there's not a fear there, but it's that if I don't tap this 3 times, I cannot tolerate it. It's not right. I need to make it right. The other thing to keep in mind for OCD, anxiety in general, is whether there's avoidance. And so sometimes parents and kids will say, well, they don't have any symptoms, but when you ask more, it's because they've avoided any situations that might expose them to the things that drive their obsessions and compulsions. And I just wanted to put these scales up so that you all have them. There's the formal ones that used to be used all the time regarding studies and in clinical practice are the CY box 1 and 2, but recently those became no longer public domain. So I don't know, those of you who use Epic, I think they are, if they haven't already been taken down, they're being taken down. But two other ones that I like that are public domain are the DOCS, Dimensional Obsessive Compulsive Scale, and the OCI CVR, Obsessive Compulsive Inventory, Child Version Revised. So you can find those online. And then just briefly on treatment. So the two mainstays of treatment are behavioral therapy. Exposure response prevention is really what you need. And that's the type of therapy where an individual that has OCD is exposed to the things that generate the obsessions, and then given tools and strategies to not engage in the compulsions, the response prevention. If someone is seeing a therapist and they say that they're mainly doing just breathing, relaxation, that's not ERP. And ERP is a type of CBT. Then, in terms of medication, we know that the serotonergic agents, so SSRIs, are frontline gold standard treatments. Fluoxetine, sertraline, fluvoxamine, clomipramine. Important thing to know about fluvoxamine is even though it's sort of named as the OCD medication, it hasn't necessarily been shown in any head-to-head trials to be better than the other SSRIs. What it can do is if you combine it with clomipramine very carefully, it prevents the conversion from clomipramine to norclomipramine. It's more serotonergic that way. And so that is one of the reasons through CYP interactions that fluvoxamine was given that label. But overall, I will usually start with either fluoxetine, sertraline, escitalopram. And I know you have really good guidelines put out by MCPAP as well, which give good instructions. Pearls regarding medication is that you really are mainly, you're hoping for full remission, but you're really aiming to see about 30 to 40% reduction in symptoms at any given dose. And the clinical impact begins within a couple of weeks. So we used to learn that it needs 4 to 8 weeks to see a benefit from SSRIs. But in reality, you should see about 2/3 of the changes that you're going to expect to see within the first 2 to 4 weeks or so. It then continues on up to 12 weeks, but overall, you really should see a signal pretty early on for any particular dose. In terms of things that moderate OCD treatment and might make it so that SSRIs and or treatment is less effective, tics, which again I'll get into in a moment, hoarding behaviors, low insight. If there's increased accommodation in the family, that also can get in the way of progress in treatment. So it's really important to have the parental component. And then additionally, ASD or PDD features. Not that you shouldn't use SSRIs in these youth, but just to kind of keep an eye on whether it is necessarily working as well. And what we know is about 2/3 of our youth respond to our first-line treatments. So moving on to tics. What are tics? They're sudden, brief, recurrent, non-rhythmic, stereotyped movements or sounds. I like to use the word involuntary to describe them. People will say they're involuntary. It's not happening outside of the child or the individual's control, but it's more irresistible, like trying to resist a sneeze or a yawn or a terrible itch. So it's not voluntary, it's not involuntary, more involuntary. They tend to jump from place to place in terms of frequency, complexity, type. They wax and wane, meaning not just in any particular situation getting better or worse, but just over months and years tend to have their own pattern of increasing and decreasing. They are highly suggestible. And so sometimes people will say, well, it can't be a tic because they only do it when I mention it. That's actually a core feature of tics, that if you speak about it, kind of like yawning, they're pretty suggestible. And for many individuals that have tics, they have a premonitory urge, this feeling, discomfort that is often relieved by doing the tic. Often kids younger than 10 have trouble reporting it, but kids over 10 are often able to say that they feel something funny that they try to relieve with the tic, although then the feeling often comes back. Similar to an obsession being relieved by a compulsion, but then the obsession comes back. Not going to play this video, but I know you'll all either have this recording or the slides. It's 4 minutes, made in, I think, the early 2000s, and just is really wonderful in terms of showing youth with different tic disorders speak about it in their own words. And so in terms of the phenomenology of tics, we tend to divide them into 2x2 categories. So there's motor and vocal tics, motor meaning physical movement, vocal meaning making a sound. Some would argue it's also motor, using vocal cords to do so, but at least for now, it's divided into those two groups. And then simple or complex. Simple meaning one muscle group involved, complex meaning multiple muscle groups, and often appears more deliberate or coordinated. And so, for example, a simple motor tic might be a shoulder shrug. Simple phonic tic might be a sniff sound. Complex motor tic might be something like that. And one of my favorite stories is about a young boy who had a sort of neck hair flipping tic. So he got his haircut cut to look like Justin Bieber's at the time. So it looked more purposeful versus it being a tic. And tics, complex tics, can also include self-injurious tics. I'm not going to get into that so much today, but this has made a lot of probably what a lot of you have seen in the pandemic with increased rates of kids presenting with tics really complicated, because it can be quite difficult to sort out what's a tic, what might be more functional. And then similarly, complex vocal, that could be words, phrases, again, though, often stereotyped. So if, a parent comes in saying that their child told them to go themselves after getting into a fight, even if they have Tourette's, just because they used a swear doesn't mean it's a tic. A tic is often said in a different cadence, tone, happens unprovoked, can happen when provoked, but also in unprovoked situations. And what we know too, corporalia, swearing tic, which is the one unfortunately most often depicted, is only seen in about 10 to 15 or so % of individuals with Tourette. And so another key component of tics are that there are a number of modifying factors that are known to increase or decrease them. So it's always important to ask about these in terms of better understanding the experience of the individual and what things they might be able to do differently to potentially reduce tics. So for example, things that are associated with tic reduction are being in flow. So if you're acting, singing, playing the sport, oftentimes kids with tic disorders will say that the tics, they just don't have them during those periods of time. Doesn't mean that it's not a tic disorder, but that's known to modify the tics. Unfortunately, alcohol and weed are also somewhat anecdotally, somewhat not anecdotally, more evidence-wise shown to lower tics. And so that starts to get really tricky when kids are in their teens and early 20s regarding self-treatment for tics. And things commonly associated with tic worsening: anxiety, stress, frustration, boredom, tiredness, illness, social situations, excitement, homework, really anything that takes you off a sort of calm euthymic base. So it could be good energy, it could be, anxiety related stress, but all of those can be associated with tic worsening. And so that's tics. So how about Tourette syndrome? So Tourette syndrome is a childhood onset neuropsychiatric disorder characterized by tics. Prevalence is probably a little higher than we think. It's probably more like 1 to 2%. But all one needs to meet criteria for Tourette are at least 2 motor tics and at least 1 vocal tic for at least a year. They don't have to be concurrent. They can come and go. And they shouldn't be secondary to a substance or another medication, but that doesn't include stimulants. So if a child has tics emerge with a stimulant, that's not a rule out for potentially having Tourette. It's more the way we think is that large studies have shown that stimulants on the whole don't actually cause tics more than placebo. For any one individual, maybe, but on the whole, stimulants aren't more exacerbating of tics than placebo. And two, it's likely more if it does occur, it's more likely unmasking what one already has the tendency towards, because tics and ADHD have such high overlap, and often around the age that one might start treating ADHD is around when you might also start to see tics more. I've certainly seen stimulants exacerbate tics. I've certainly seen them help tics. But on the whole, I never won't use a stimulant for ADHD if indicated because the child has tics. Other tic disorders are chronic, persistent motor or vocal tic disorder. Same criteria, but either just motor or just vocal. And then the other category that I think is evolving and a little bit confusing right now is provisional or transient tic disorder. And so this is any number of motor or vocal tics as long as it's less than a year duration. A lot of people speculate that it's part of a typical development and that up to 20 to 25% of youth will have a tic at any point. That said, there was a recent study that showed that of those caught really early, like within the first few weeks of developing tics, 70 to 90% continued to have tics over the next many years. So it's a little unclear how we go from 25% to 1 to 2% Tourette, but I think that's an area of the field that's evolving still. And
Dr. Greenberg,
yeah,
can I just break in with a quick question? It's Barry Smith,
definitely.
by the way. I'm moderating. I'm going to moderate the questions. Thanks again for being with us. Just you had mentioned that that weed seems to be associated with the reduction of tics by subjective reports, and I'm not sure if it's subjectively been measured, but I'm wondering if there's any work being done on either CBD or analogs of other cannabinoids in terms of treating tic disorders, or if that's kind of just kind of not ready for prime time.
No, it's almost ready for prime time. So there was a really large study, I believe it's based in Germany, but it's probably international or multiple sites looking at an analog. What they find is that CBD doesn't actually help tics, that in general you do need some THC, which is really tricky given, what we know about the negative impacts of THC. And so even the Cochrane, the last one I saw, Cochrane basically says, like, there is likely some evidence here. We cannot fully say it, but it's not no. And then I think the results of it's called Canatics, that study just came out a few weeks or months ago. And if I'm remembering it, it did show that a combo of THC, CBD did improve tics. And so I can't prescribe it. I won't prescribe it. But again, we have some kids who've tried upwards of 10, 15 different medications without success. And so I'm looking forward to more info about that so that it can be a tool one could use safely in the right circumstances.
Thank you so much. That's great.
Yeah, cool. So in terms of the epidemiology, it's known to be in natal males more than natal females, though I'm particularly interested in this. There's increasing studies on whether there's a female phenotype for Tourette that might have been missed, given a lot of the early research was on natal males, but that's more for another day. I'll touch on it in a slide or two. Mean age of onset of tics is around 5 to 7, but the maximum severity that we see is often early adolescence, which is really tricky because these are often middle school age kids who might be struggling anyway. And now you're adding in tics and a lot of these co-occurring conditions. And so it could be really, really hard. I would say the main importance of recognizing tics from a pediatrician's perspective, although I'm open to what you all think too, is not for treatment purposes. You only treat tics if they are bothering the child or getting in the way or causing impairment, but more because if you see tics, they're really the tip of the iceberg of what else might be there. And so this is a handout from the Tourette Association of America. I really like it because it basically shows what a lot of families that have youth with tic disorders experience in terms of the co-occurring symptoms. And so this is more just a list of all of these, but we know that up to 90% of individuals with Tourette will have at least one co-occurring diagnosis. The most common are OCD and ADHD. Again, upwards of 50% for each. 2/3 will have at least one. About a third of individuals with Tourette will have all three. And then we also see mood disorders, be it depression or more bipolar disorder or mood dysregulation, NOS. We see disruptive behavior, anxiety, high rates of anxiety. I think 36 is probably an underreport. Body focused repetitive behavior disorders, hair pulling, skin picking, sensory disturbances, impulsivity, disinhibition, executive dysfunction, kids who will inadvertently blurt out socially inappropriate things. They're not tics, they're not stereotyped repetitive, but that filter is less present. Sleep disorders, high-related learning disorders, and at the least autism spectrum symptoms, if not full ASD. And so when I'm evaluating a young person that has tics, I'm often thinking of this developmental course chart, and depending on what age they are, what I might be expecting, if, really with any condition, but particularly if they started with ADHD, now have some tics, I'm keeping my eye out on anxiety, eating, OCD, mood, substances going forward. So typically in tics and Tourette, they tend to follow a specific clinical course. And so what you often see is simple before complex, motor before vocal, and proximal or rostral to more distal caudal, or top to bottom. So basically head, neck, and out. And then regarding the clinical course, but again, I wonder if this is going to be shifting, tend to think of it in rules of thirds. On the whole, chances are on the patient's side that the tics will improve as they get older. So about a third resolve, even though still evidence if one looks closely, about a third might improve to a degree. About a third remain, with about 10% continuing to have persistent disabling symptoms. We're still working on understanding who is likely to be in which category, but it's not just severity that'll dictate how one will be in the future. So someone can have really severe tics, but still ultimately have it resolve. What's interesting, again, to point out is whether there is more of a sexual dimorphism and whether there are sex differences in patients with Tourette, because a lot of recent research is showing that perhaps for females, there's a later onset of tic starting, and they are less likely to resolve with time. Clinically, that is what I've seen. Obviously, I want to see like larger and larger studies with, thousands, tens of thousands of individuals, but it's something that I had been noticing for a while that I'll be interested to be able to follow up on in the future. And also more likely to have mood disorders, anxiety disorders, OCD, compared to natal males. So we often talk about all these comorbidities. You have tics, OCD, ADHD, BFRBs, sensory hypersensitivity, mood dysregulation, anxiety. So I often explain to parents that the reason that they're often seen together is that they're all associated with dysfunction, dysregulation of this corticostriatal thalamocortical circuitry network. And basically this network is involved in regulation and inhibition. And so when it's dysregulated, disrupted, you see trouble with regulating thoughts, movements, emotions, and also reward circuitry is highly linked with this. So parents with youth with ADHD will say, but they can focus for hours on, XYZ. And what I often explain is it's ADHD is not a disorder of inability to focus. It's a disorder of dysregulated focus. You can focus a lot, you can focus a little, but it's hard to get where you want to be, given the way one's brain is wired. In terms of impact on life, it's pretty upsetting. There's a more recent survey that just is coming out in the last couple weeks, but up to 30% of youth per parent report have engaged in self-harm or suicidal ideation. Of those that report suicidality, the biggest challenges are these comorbidity conditions, feeling discriminated against, and the negative impacts on the school experience. Over 90%. Over 2/3 of kids report worse peer relationships, difficulty with friends, worse quality of life. So knowing all that, how and when do you treat tics? So again, you don't need to treat tics simply because they're there. A lot of psychoeducation is needed around that, to the parents, to the child, to the school. But when you do treat tics is when they are causing pain, when they are causing social functional problems, or psychological distress, depressive and anxiety symptoms, low self-esteem, social withdrawal. There are two types of treatment, mainstays, gold standards. The behavioral treatment is called CBIT, Comprehensive Behavioral Intervention for Tics. It is not CBT, CBIT, different treatment. And then the other treatment is pharmacological or medications. And in general, the goal when treating tics is not to quote unquote cure or go to zero. It's to reduce the severity and the frequency, and balancing that with potential side effects, speaking more from a medication side. So that basically trying to optimize what's the lowest medication doses you might be able to use to make the tics reduce to the point of tolerating which is, we need better treatments, but also knowing that on the whole, they will get better as kids get older. And another overall treatment guideline is managing these co-occurring conditions, because I don't know if I said it explicitly, but overall, most individuals with Tourette, it's the co-occurring conditions that cause the most problems and not the tics themselves. And so CBIT, I'll briefly cover. It basically has three components: habit reversal training, which is when you work on sensory awareness training, so awareness of the tic. You develop a competing response, something incompatible with the tic, and social support, which is often involving a parent to basically praise and prompt once, but not nag, not get into a situation where there's more fighting because of the tics, and that's all more coordinated in a structured treatment. There's function-based assessment intervention, and this is when you work with the child and the parent to go tic by tic and examine and identify which are these modifying factors, internal or external, that are either exacerbating or improving tics. And then I think of habit reversal as like directing towards the tic. Function-based is directing towards the environment. And the combination has been shown in meta-analyses to be as effective when done correctly as atypical antipsychotics. There's often also a psychoeducation and or like relaxation breathing component, but the habit reversal and the function-based assessment intervention are the ones that are shown to be the most effective. Pharmacotherapy-wise, there's only 3 FDA-approved treatments for Tourette: Pimozide, haloperidol, and aripiprazole. The majority of our treatments are used off-label. There are few randomized controlled trials, and so a lot is more based on expert consensus. That said, there are a lot of medications in the pipeline, and so for the first time in years, I think there's increased hope about what's coming. So we think of the medication as being in 3 tiers: the alpha-2 agonists, then a tier that we really need, then atypical neuroleptics, risperidone, aripiprazole, et cetera, and then typical neuroleptics, haloperidol, Pimozide, fluphenazine. Overall, as first tier, lower risk of side effects, lower risk of effect. About 30% will get 30% better. Tier 2, the atypicals, more side effect risks, as we know, about 2/3 will get 2/3 better. Typical neuroleptics, about 3/4 will get 3/4 better. And so I know you'll have the slides. Here are, as you can see, the doses needed of these medications are used in Tourette is often lower than what would be used for either psychosis or mood stabilization. It can be tricky to describe to a parent why you're prescribing an atypical antipsychotic when clearly there are not psychotic symptoms. And so what I often say is dopamine modulating agents. And I would say it's important to always try an alpha agonist, even though, again, we know it's not necessarily as effective as our other medications. One thing to remember is that alpha agonists are more effective in youth that have co-occurring ADHD versus youth that had tics without co-occurring ADHD. Personally, I like clonidine, Capve, clonidine, and Tenex. Even though it's short acting, you can still give it at night and see a benefit on tics over the course of the day. So that's something I'll often explain to parents. It doesn't just have to be in the morning, especially because they can be so sedating. I'll sometimes, but rarely use Intuniv, just because there was a randomized double-blind trial that Intuniv specifically did not beat placebo for tics. ADHD, impulsivity, great. But if all else is equal, I might lean towards Capve. And practically speaking, I rarely, if ever, even though I specialize in this, start with an atypical or a typical agent. Again, unless like symptoms are incredibly severe or there's a clear bipolar or other component that makes me want to use those. There is a few of these medications in this middle tier. Topamax, topiramate, which some evidence start 25, can increase by 25 weekly until 50 twice a day. Geodon, ziprasidone, shown to be non-inferior in meta-analyses, possibly less weight gain, less side effects, but you have to watch QTC and take it with food. Flufenazine, which again, in that high potency category, but a couple studies showed maybe less side effects. And then I won't discuss these at all, but these are the new agents, some of which have already shown actually do not help, but a lot in the pipeline. The ones I'm most excited about are the echo-PPAM and potentially these herbal components. And then again, as I mentioned, the cannabinoids. For time purposes, I will skip this other than to say we have AAN guidelines. CBIT should be initial treatment if you can find providers. There's a lot of work going on right now to make that more accessible to therapists and patients through remote-based treatment. You want to provide education, and you want to assess for and treat these co-occurring conditions. Not going to cover this, but just I wanted everyone to have it for their slides. And likewise, this is a really cool graphic of all the different medications and treatment trials out there, some with more evidence than others. So the last thing I want to touch on before I pause is the combination of tic-related OCD and whether it differs from non-tic OCD. And so it does. And in fact, tic-related OCD, meaning the person has co-occurring tics or Tourette and OCD, is shown genetically to be more likely to Tourette than to OCD. And it's more common in pediatric onset OCD. And it's often associated with particular OCD symptoms like that not just right, or I have to make it just right, and intrusive forbidden thoughts. A lot of checking, touching, writing, rewriting, evening up, symmetry. And so when you hear those sorts of symptoms, keep an eye out also for co-occurring tics. And a term I like to use a lot with kids and parents is Tourettic OCD. And so it was coined back about almost 20 years ago. And it can be confusing because it can either refer to the broader set of symptoms often experienced by those with co-occurring OCD and tics, or it can refer to a specific type of OCD, like that just right or symmetry, which sometimes I'll refer to as more of a Tourettic OCD. It's not fear-based OCD. It's more of this either sensory or Tourettic OCD. And what's interesting is for those that have Tourettic OCD, and this is a particular interest again of mine, it's associated with male sex, earlier age of OCD onset, more OCD impairment, sensory hypersensitivity, ADHD, BFRBs, anxiety, depression. As you can see, basically that circuitry I spoke about earlier. And again, it's more of this sensory phenomenon, these just right feelings versus fear-based. And so when you're doing ERP, you need to make sure that you're not just trying to target fear, but more trying to help with distress tolerance. Okay. Another important thing to note is you always start with SSRIs as first-line treatment for OCD, but if there's co-occurring tics, the POTS, the big OCD trial, demonstrated that when they look at just those with OCD and tics, sertraline didn't actually beat placebo in that population. So again, always start with it, but I'm always kind of keeping a closer eye on whether the SSRI is working as well if I know that the individual has co-occurring tics. There's a bunch of augmentation strategies one can use. The most effective, fortunately, unfortunately, is the typical or atypical antipsychotics, specifically haloperidol, aripiprazole, and risperidol. One could also, though, always try adding glutamate modulators, which Namenda, and N-acetylcysteine, topiramate, or even alpha agonists, but less research on that, even though empirically it makes sense. And so finally, I'm often asked about distinguishing between tics and compulsions. And sort of a quick and dirty way to ask is what's driving the behavior? If it's more of a thought or an anxiety, might be more of a obsession driving a compulsion. If it's more of a feeling, sensation, one might think of it more as a premonitory urge driving a tic. But as you could probably guess, there's a significant overlap where sometimes there are more sensory, not just right, driving compulsions, Tourette OCD, sometimes thought anxiety driving a tic-like movement, which a patient at some point called a ticulsion. And so I really like that. So you see them a lot together. What's tricky is we treat them differently again. So SSRIs for OCD, alpha agonist atypical for Tourette. And often if you're seeing both, you need both types of pharmacological treatment. So one won't treat both. And wanted to put up some resources. So the International OCD Foundation is really great. The MCPAP OCD Clinical Pearls and Guidelines, really helpful. And then I really, I guess, conflict of interest. I'm on the medical advisory board of the TAA, but I think they have a lot of really, really good information for parents, for kids, for teachers, including these resource folders for that last link that you can download and then give to families and schools. And so I'll end there. Thanks, everyone.
Thank you so much, Dr. Greenberg. So that was a really wonderful talk and really appreciate it. Couple questions that came up earlier in the talk, and I didn't want to stop you because you had moved on to Tourette syndrome, but it came up again actually when you were talking about OCD and Tourette's. Is a question about Lamictal. One of the audience members was wondering, not necessarily for tics plus OCD, but just as a third line treatment for OCD, whether you have any thoughts about that.
Yeah, there's a little bit of evidence. The evidence isn't great. I don't remember off the top of my head, but I think in like larger trials, it wasn't shown to be better than placebo, but I'll certainly use it as an augmenter, especially if there's mood lability. And so again, because I was talking about that circuitry, you often see, even independent of bipolar disorder, just, kind of 0 to 100. And so if the person has OCD that's moderately treated, but room to go and mood continues to be a significant issue, I'll augment with Lamictal, but I won't typically augment with Lamictal unless there's a co-occurring reason that it would be indicated.
Got it. And of course, we would always encourage people to call McPat for advice if they were going to be moving into any of these areas. And of course, these are for treatment-resistant patients.
Right.
Yeah, and the same, I think, wondering about memantine and other glutamatergic medications like N-acetylcysteine and things like that.
Yeah, I find the glutamatergic agents so difficult because glutamate is like the main excitatory neurotransmitter in that circuit, but a lot of the so theoretically, these medications should all work and help, and I've seen them do it, but I've anecdotally many, many, many times seen them not do it. The good news is outside of Lamictal, SGS, they tend to have limited side effects. And so I think it's worth a try, but if symptoms are pretty severe, I don't often expect to get major benefit with the more glutamatergic ones. Sometimes if the person has OCD, difficult to treat with executive functioning, anxiety, I will try Namenda. I know there was a study that just came out talking about Namenda for BFRBs. I think interesting, worth trying given the risk-benefit ratio, but I can't say I've been as impressed compared to, for example, when you use like an atypical and you see it work. Again, then you're in that camp. So now you're monitoring side effects, considering metformin, other things. But I would say glutamatergic, worth a shot if you have the time, patience, and, limited risk.
Thank you. Another question came up about psychotherapy referrals, particularly related to ERP, but also, the tic disorder sort of work. It's a big challenge, as you would imagine, as far as accessing these kinds of treatments outside of an academic center. But do you have any recommendations?
Yeah, and edit this out, I guess. I know it's recording because I don't have any like money in any of these places, but one that I've been referring to a lot that's been really good for kids is NoCD, NOCD. I think .com and it's online treatment. So it's not in the home or in the office, but they cover many insurances. And so that's one that I really like. I think I can find it later. It's ticsstopper dot excuse me .com. But I don't know if that's the website. So there's a few though of these
Yeah.
online sources now, but you're right, it is really hard. And TAA is working in conjunction with a few PIs to develop, like I actually saw an early version of this model to both treat other clinicians and just to increase access for patients. So I actually think there will be a major improvement with this in the next year or two.
Yeah. By the way, unfortunately, I think it came up in the introduction that we're not able to offer CME credits, so we don't
Oh,
have the same strict rules about commercial conflicts of
bias.
interest. But we do care about that. We don't want to be
Right.
having dual relationships and things like that. But there is a company called InStride,
Oh,
which is
yeah.
partnering with McLean,
Yeah.
which is another telehealth platform, but it's offers a lot of support outside of just the telehealth and coaching, actually, around some of the work that kids need to do outside of
Yeah.
their appointments, which is kind of interesting.
InStride is great. Also MAMP, I refer if symptoms are more severe. McLean Anxiety Mastery Program, they're
Yes.
also wonderful. And then for higher level, Bradley over in Rhode Island, Rogers in Wisconsin, OCDI Junior at McLean. So those are often the bigger ones that we're thinking. But yeah, no, InStride is also really good.
Thank you. So there's another question about sort of the choice of the SSRI, and I think I know the answer to this because there's a dearth of head-to-head studies, but this audience member is wondering if there's any differences in terms of the choice of an SSRI if OCD is complicated by GAD. But
It's a fair question. So right, there's no right answer. The way sertraline has the most, I think, data on it in anxiety, at least per Jeff Strawn's group. And so, if all else is equal, it's more that I'm looking at, is this a child that's complaining of GI side effects or GI problems? And if so, I might be less likely to choose sertraline versus like fluoxetine. If I'm worried about potential like manic or mood disorder, I might be less likely to choose fluoxetine, given the long half-life. Duloxetine, which is approved in GAD, is less serotonergic and so less likely to help OCD per se. However, what sometimes happens with a lot of the SSRIs is that you get activation, especially in these younger kids, not necessarily mania, but can't tolerate because they do get silly, hyper insomnia, and duloxetine, the SNRIs, are less likely to make that happen. So if you can't get away with using an SSRI for OCD, you could try SNRI, knowing it'll be less effective, but you also might get better tolerance. But if there's co-occurring GAD on the whole, it doesn't necessarily change what I would start with. One other quick thing I forgot to mention is that there's a bunch of new data looking at like gene profiles, and the pharmacodynamic side I think is less evidence-based, but the pharmacokinetic side, looking at the CYP interactions, 2C19 for Lexapro, escitalopram. There's a study that showed if you're an ultra rapid metabolizer, 30 is equivalent to 10 if you're a poor metabolizer, equivalent to 20 if you're typical. So we often say stop at 20, but if you're an ultra rapid metabolizer, you need at least 30, and then we'll sometimes go up to 40.
Another reason for McPath consultation. So the last question, and I know you have to go momentarily, and I know you could probably talk about this for a whole hour. So all I think we're looking for is some pearls here. But I wonder about some of the autoimmune pandas, kinds of issues, that I think people wonder about when we start talking about the combination of tics and OCD.
Yeah, I gosh, yeah, I have sort of I would say the big takeaway is, it's recorded. I'm not so convinced how different PANS pandas are from just regular Tourette and OCD. I think it's likely a continuum. What we know about OCD and Tourette in general, forget PANS pandas, is that there's high rates of autoimmune in the family, higher risk of developing those if one had an early childhood infection, and likely linked with inflammation itself. I think more PANS pandas, which it's not a religion, like I believe in it, like it's real. We see it, I've seen it, I've treated it. It's less about the symptoms, because as you saw in Tourette, you can have all of those symptoms. It's the abruptness and intensity of the onset and this sort of just overnight change. Those are the kids that I tend to think more in the PANS pandas, and they're often a little younger. And but what has not been shown is that no one has shown that anti-inflammatories don't work in typical OCD or Tourette. No, it's like it hasn't really been studied. So I think kind of like what we know now about bipolar disorder, schizophrenia, there is an immune component. And a study just came out a few weeks ago. That's something that I've been saying to parents for a while, which is that it's likely the same genes that predispose you to developing OCD and Tourette that simultaneously predispose you to having these reactions to these illnesses and autoimmune conditions. So it's not necessarily causal, it's probably more correlated, but then whether or not there's like a hastening, if you get sick and then it puts it into motion, what likely might have been happening anyway. A lot of kids with PANS pandas have parents with Tourette and OCD. I don't think that rules it out. I just think, again, it's very, very muddy. So,
I know it was an unfair question as well at the very last moment, but yeah, I like the way that you addressed it. And so we are out of questions and we're out of time. And again, I want to thank you so much for speaking with our audience today. And I think it was fascinating, and I'm sure everyone appreciated the talk. And so we're going to end now, and we're going to just remind everyone, as always, to fill out your survey so we know what you think, and so we know what kinds of future presentations so that you'd appreciate us organizing. But thanks again, everybody, and have a great afternoon.
Thank you so much, everyone. Bye.